So we have a little bit of a mix in the room. Hopefully, I believe we would all agree with this general statement that it says clients here, but we can easily substitute in students, kids, whatever we want to call the folks we work with. And that is, our students deserve the best chances we can give them. Now, best is one of those words we love to throw around in education. I've heard Joe Olney, who's one of the previous director at the University of Southern Mississippi School Psychology Program, talk about school psychology best practices. And in not a very favorable, and that may be a little shocking because that's our buzzword, right? Best practices. We're going to use best practices for these students. Well, okay, what is best practice? How do we know what best practice is? And more importantly, do we have the resources and the ability to give the absolute best intervention, best possible thing we could do to every child in our district? His argument is not that we shouldn't do the best we can for the students in our charge, it's that we have to be reasonable and understand that there are limitations in our context that prevents us from doing the things we need to do, or that we should do if we followed this best practice mantra. I'm sure that while this doesn't feel comfortable to sit with, every one of you knows what I'm talking about. Because you think about, oh, I have this kid I'm working with right now. He's a wonderful little boy. I need to do X, Y, and Z, and he needs to have this amount of therapy or intervention work every week. Unfortunately, I'm not able to do it because of my caseload. The teaching staff is already overworked and over-requested, so I can give them some basics to add in, but we can't give him the dosage of intervention that would be considered best practice. Okay, well, once again, we're still uncomfortable, regardless of how logical that is. So what do? How do we handle that? How do we deal with the decision making when we're satisficing over maximizing? So let's see here, best way to get into this. So we're going to be talking about the maintenance and de-implementation of low-value practices. And you may think it a little odd that I'm beginning with evidence-based practices, empirically supported treatments, empirically supported instruction. But I think you have to have one to have the other. You have to understand them both to be able to make the decisions we have to make on a daily basis with our students. So what's the point of school psychology or counseling or coaching? What is the point? What are we trying to do? I think ultimately we're trying to solve problems. Now this is extremely abstract and pretty general, but here, bear with me for a second. We have a child who's not reading particularly well. We need to solve that problem. We have a child who has difficulty with math fact fluency. We need to solve that problem. We have a child who's experiencing emotional distress in the classroom. We need to solve that problem. Our goal is to solve problems. And as we've been called to do many times, preferably big problems. Solve big problems. If we can accomplish that, we've largely done our jobs. And that's what's led us in part to the evidence-based practice model. Now, this may not be the one you're as familiar with. You're probably used to the three-legged stool. I refer to that as the hand-me-down stool. It's the hand-me-down stool because it does not fit what we do. It assumes that you have all the resources in the world to do the things. Because nowhere on that stool, nowhere in that model, do we find limitations of the context. That was built for doctors in hospitals and clinics. That was built for clinical psychologists working out in their own clinics and community health centers. Not to say that they're flush with resources, but it's a different world. It was built for people who have absolute autonomy in decision-making over treatment. We don't often have that, do we? Even when we do have the ability to say, this is the intervention we're going to choose, oftentimes we have to yoke that a bit, right? We have to say, okay, look, I realize that we should probably do interval sprinting here, but ain't nobody heard of that, and so now I have to back that up a little bit. We're going to simplify, and then we'll come at it another way. All right? Okay. So let's talk about this model just a little bit. All around here we have the environmental and organizational context. We exist in that space. We have to consider the limitations of that space in what we do. It is as simple as that. We have our tried and true best available research evidence there at the top bubble. Everyone here knows what that is. I'm really talking about the developmental science of learning, the developmental science of growth and general maturation. I'm talking about empirically supported treatments, empirically supported interventions. I don't think that one is ambiguous here today. This one's also going to be really familiar, although it's worded a little differently. We're talking about client population preferences. Notice that the word population is in here, because it's not just about the preference of the student, the preference of the parent. We would like for it to be, perhaps, but it's not, right? It's also the preference of the administrators in the room. It's also the preference of the teachers who will be implementing these interventions, because Lord knows we don't have the time to be there doing it, unfortunately. So we have to take those things into consideration. What are the values of the school, of the team, of the administrators, of the parents, of the student? Those are all part of client preferences that's not well expanded in the original model. And then, of course, we have resources, including practitioner expertise. And now, this was written, again, still, this model as well, was written with clinical psychologists in mind. It does a better job of capturing what we do, but it is not perfect because of this word practitioner. Because the practitioner, what they really mean here, is the change agent, the person doing the intervention. That's not always the practitioner. In fact, I would say it's rarely the practitioner. That's often up to instructional staff. Sometimes it's the primary teacher, sometimes it's a resource teacher, sometimes it is a teaching assistant. We do what we can in the schools, right? We get by. So we have to consider evidence-based practices, I think, in a different way in the schools. And once you start considering it this way, best goes out the window. Because we're no longer choosing the best approach. We're choosing the best approach viable in our context. Okay, well that's more complicated, first of all. Because let's assume that we have this great given on high list of interventions we could use in this situation. There's maybe a couple at the top that simply aren't viable in the schools for whatever reason. We have a set beneath that might work, and then a set below that. The question is, our setting tells us which ones probably aren't going to work because of resource and all that, right? How do we define that lower boundary? How do we talk about, well, what is the bare minimum standard for an intervention or recommendation or accommodation that I can choose in this situation? Well, I think this is where we have done a sort of a disservice in talking about practices and interventions, because we've done a wonderful job of saying, ESTs, everyone should use ESTs, they're wonderful, great. That's great until you realize that everyone bills everything they do as an EST. Every single program, I can literally create a program right now, completely novel, no research evidence for it at all, and call it evidence-based, because I've based it ancillarily on some theory that exists out there. It's research-based, woohoo, good, go forth. So how do we figure it out? We have to have some strategy, no matter how imperfect, to identify that lower rung of minimally acceptable practices. So solving problems requires using strategies that work, yes. But the problem is that we're really good at fooling ourselves about what works. We're exceptionally good at that, actually. We even seek out evidence that we're right, especially if we've been using a practice for a while. We don't want to believe that I've mistreated or misdiagnosed or misassessed these 500 kids I've worked with over the last decade. We don't want to believe that. And so therefore, that practice I was using was absolutely not a problem. Except we all know that's also not true, right? We know that's not true. Education, medicine, psychology, counseling, social work, all of these fields have a lot of practices embedded in them that simply do not work. They don't work. They don't do what they're supposed to do. It really is that simple. So think about your area. Think about the things that you do most. What are some things that are common that you see your colleagues doing, or maybe you see on listservs that folks are recommending, that there's simply no evidence that that works? It's not a comfortable thing to sit with and think about. I'll own that. So let's start by picking on some other people. This is the poster child of that don't work. I know it's been reinvigorated, which is massively entertaining because, nothing says governmental efficiency like, well, I know we did 20 years of this and it actually caused more drug use, but hey, let's try it again with a lion this time. Maybe it was the mascot. That was certainly the problem. So we have DARE. Ultimate example of this can potentially, well, we know it didn't decrease drug use, and there's some back and forth evidence that it may have actually increased exposure to drug use. Okay, so that's one good example. There's a lovely elephant in the room there. Sleeping on a belly for babies. This was common medical recommendation for years and years and years until we realized that children who slept on their bellies were more likely to suffer sudden infant death syndrome. Right? And so there was a huge shift in medical recommendation and accommodation advice regarding how to have children sleep. Certainly, if you go back and watch movies from the 50s, 60s, 70s, and 80s, you almost always see just massive amounts of cover and blankies and everything else in these cribs, and now they're like, absolutely not. Right? Like, it should be nothing in there for the child. And mental health care, we have tons of these. I'll be real clear. I'm not casting stones to other people. I'm happy to stand in front of the stones myself. We have rebirthing therapy, which is absolutely absurd. I'm not going to go into it. If you're curious, look it up later. Facilitated communication, yeah, pretty bad one, pretty egregious one, not going anywhere. Cognitive profile analysis, patterns of strengths and weaknesses, it does not work. Okay, thought field therapy, critical incident stress debriefing, scared straight. Grief counseling for normal bereavement. All of these things don't work. There's older ones, right? And we've learned to get rid of some things that over time, like lobotomy, phrenology, hydrotherapy, calming chairs, and so on and so on. Right? There's lots of these things that exist in our world that just don't work. So how about education? Clip charts. The devils. All right. Balanced literacy. I think we can all. All right. Delaying intervention in general. Bad practice, but very common. Retention. Kind of the same thing in some ways, right? It tends to take the place of actually intervening in a meaningful way. Clip charts. Lots of fads. Do you know how many different poster packages you can buy for PBIS that don't actually change the practices around PBIS? It's incredible. And they all have wonderful acronyms, right? Empower. I don't know what it stands for. Well, protect. Okay. Good for you. How much was that? All right. How much of that money could you have put into other things that would have worked? I worked with one school very briefly as a consultant. They did not like me. In Texas, they had 22 different interventions in place for PBIS and bullying, all at one time. Of course, they weren't doing any of them to fidelity. And of the ones they had chosen, only about 2 had I ever heard of. Now, I'm not saying, again, that I'm end-all, be-all knowledge base of evidence-based practices, but if there are 20 practices that you have implemented in your school, and I'm sorry, 22, and only 20 of them I've not heard of, I'm willing to do the digging and find some research, but that's not a good start. It's a little concerning. We love our fads in education. It's all right. Let's step back. Let's take a broad picture for a moment. Let's talk ethics. What do our ethical codes and ethical virtues tell us about how we should engage in practice? We're going to primarily focus on the top two here, beneficence and non-maleficence. Okay? Beneficence is do the best thing that you know to do. Only cause good. Do not actively cause harm. We're getting into non-maleficence very quickly there. But see, non-maleficence goes a step farther. We usually talk about it as don't cause harm, right? Do no harm. That's our lovely phrase. Borrowed, of course, from Hippocrates. But really, when we talk about non-maleficence, there's a second part that we often forget, and that is do things to prevent harm as well. And I think that's the part that we often miss. Not that we're trying to cause harm, but sometimes our actions do not actively prevent harm as well. How am I defining harm? That's important in education, right? It's real clear when we're talking about medical situations, when we're talking about surgery and medication. It gets a little fuzzier when we're talking about education. Skip past that. I'm going to come back to that. That's an important point, and I want to spend some time on it, but I want to talk a little bit about evidence-based practices and its relation to the non-maleficence and beneficence for a second. See, I think of evidence-based practices not in this sort of broad, this is what we do kind of approach, but instead of having both positive and negative qualities, positive and negative characteristics. The positive, increase the potential to obtain the desired result with any given case. That's the purpose of evidence-based practices. Now, what is that desired result? Well, that depends. Depends on the values, the preferences, the situation, the problem, the context, and so on and so forth. Right? I worked in inpatient care for a bit, where we would take elementary school kids whose behavior was so disruptive they could not be in the classroom. They would pay to have them sent to our facility instead. That child, if we looked purely at like grade standards and expectations, should have been learning long division. I focused on sitting at a desk. And so our expectations, our preferences are very idiographic, right? They are very much based on the values of the people who are in front of us, the stakeholders in this moment. And sometimes it's easy to grapple onto those goals and values and preferences of the larger system and forget that we're looking at one tree and not a forest. And sometimes that one tree needs a little bit more help in a different way than what the forest overall needs. Now, that child figured out how to sit at a desk, returned to school, and has done exceptionally well for someone who effectively missed a year of instruction. But did I do harm to that child by taking him out of instruction for a year? An argument could be made that I did. I removed him from the general education environment. I removed him from opportunities to respond in reading and math and history and so on. Absolutely, I did that. And yes, was it harmful? Absolutely, yes. So do no harm. How do I balance that? Well, I have to recognize that do no harm is a bit of a misnomer. It's do minimal harm while maximizing the most good. And that brings us to negative. The negative characteristic of evidence-based practice is to decrease our potential to cause harm with any given case. We should be minimizing the harm that we do, the harm that schools do, the harm that our administrators do in any given case. I realize that's a lot to put on our shoulders. Bear with me. Types of harm. Well, obviously there's physical harm. I'm not going to explain that one. You all know what that is. For the most part, we get to not worry too much about that, unless we're doing physical restraint or we're doing functional behavior assessment with particularly aggressive or self-injurious behaviors, that's really not something we have to think too much about. Of course, we do have to think about it in those situations. Harm to others. And I want to start expanding the definition of harm here. I'm not just talking about physical harm here. There's a lot of emotional distress that comes with the evaluation process in schools. Parents go through a hell of a roller coaster during that process. And if we get it wrong, our roller coaster is a lot worse. Dropout. And I mean this both in terms of intervention therapy dropout and in terms of educational dropout, right? If we fail to prepare a child for high school because we failed to provide interventions on time, we failed to provide empirically supported interventions, at high school their chance of dropout is what? Higher or lower? Much higher? Yeah, much higher, right? Because they're not prepared for that situation anymore. It's not benefiting them, most likely. Loss of financial, we like to say as school psychologists that our services are free. That's a comment I've heard from a lot of school psychologists. That's not entirely true though, is it? Our services are not free. We're paid for our time. We're paid for the resources that we use within the schools. Teachers are paid for their time. We pay for the resources they use as part of instruction. Classroom, and by we, I mean the greater school system, and so on, right? On top of that, whenever a parent has to come out for something extra, that's a potential loss of financial income for them. So we have to be cognizant that when we're pulling someone away, pulling someone out, moving things around, shifting what intervention or instruction we're using, we're potentially causing financial harm. Loss of instructional time, again, I think this one's pretty obvious to most of us. Loss of time in the classroom. But also, loss of time with an empirically supported instruction or treatment. Right? If I recommend that a teacher use clip charts, and they use clip charts, this one came up, so I'm going to use this one as my whipping boy today. And they use it for 6 months. That's 6 months of that year that they didn't use check-in, check-out, or the good behavior game, or something else more effective, right? Even lower tier, more simple classroom management strategies. Loss of professional time. Look, we like to all be altruistic in what we're doing. I get that. But our time is valuable. And I believe the average number of cases on a school psychologist caseload in 2020 was 52 full evals for a year. That's massive. That's a large number, especially when you add on top of that counseling, academic interventions, meeting, administration, report writing, and so on and so forth. That's a lot of our time. Our time is valuable. So spending our time doing things that don't work is a very, very poor decision. And we talk about assessment specifically, because this is what I used to research. I used to research assessment. That was my bread and butter for a while. And so when we talk about assessment, we're talking about inaccurate labeling and placement. We're talking about disproportionate labeling and placement. And we're talking about ineffective treatment selection as a result of bad assessment. There's a wonderful article by Matt Burns. It's something like, can 200 studies be wrong? And it's talking about the use of neuropsychological assessments to select interventions for academic disabilities or academic deficits. And effectively, there's no evidence. It doesn't work, doesn't do a thing. And yet we prescribe to it this ability to help us get to the best treatment or the accommodations or the supports that this student needs. Honestly, we could have gotten to those same interventions in sports just by flipping through a menu of options. My favorite example is, well, Dr. Farmer, you know, he has a pretty low working memory index, so I think he needs increased time to do X, Y, and Z. And I said, oh, before you did the assessment, was he finishing his assignments in class? No. You already knew you needed increased time. You spent 30 minutes on 2 subtests and then no telling how much time writing that up to say a thing you already knew. And that's not often a popular opinion, School psychs are real defensive about their cognitive assessment. I've been yelled at. That's okay. You can yell at me. So let's talk about that bottom rung. Let's talk about moving towards identifying those low-value practices now. That's why you're here, right? So low-value practices, let's skip this slide because this is just a summary. Low-value practices are those that have not been shown to be effective or efficacious. In other words, there's no research, period. These are interventions without adequate evidence to inform their use. We simply don't know if they work or not. Okay, my example for this one was zones of regulation. But now there's a study that came out just, I believe, last week that says that it does not work. So I have to move this to a new category now. No one should be surprised. Clip charts, though, still fall in this category. Because to the best of my knowledge, and I search pretty regularly before I do these presentations, no one has done a study on clip charts. So at best, there's no evidence to support their use. Okay, so that's what we're talking about here. Now, does that mean that all novel interventions should be disregarded and we should only use the tried and true? No. But the way that we go about using a novel intervention or strategy has to be held up to stronger standards, higher expectations. We have to do a bit more to prove that what we're doing is the right thing to do, or at least the right enough thing to do. The good enough school psychologist is what we're aiming for here. The second category of low-value practices, these are practices that are less effective or efficacious than another available practice. Less effective or efficacious. So, what are some examples here? You can go back to balanced literacy if you want. It is less effective than other strategies, than explicit systematic instruction. Okay. In the mental health area, there's lots of things we could talk about with regard to cognitive behavior therapy and kind of getting into those weeds. Let's not do that. I think this one's pretty straightforward. There is a preponderance of evidence that says that treatment A is better than treatment B. Therefore, you should choose treatment A unless you have a damn good reason to choose treatment B. And that goes back to context, right? I want to be really clear. I'm not saying you should never choose treatment B because it's a bad treatment. What I'm saying is that as long as treatment B meets other standards and still is effective, just not as effective, there may be a good reason to use that, right? And this kind of goes to the implementation science side of the world, which is outside of the scope of this conversation. And if I go there, I'll run out of time. All right. The third category, I don't suspect anyone will disagree with this one. These are practices that cause harm. I think we can talk about physical restraint here. We can talk about retainment here. We can talk about, well, potentially we could talk about clip charts here. But the evidence is not clear on if they cause harm or not. Like I said, there's no evidence, but there is the potential that they would, seeing as how they're largely punishment-based systems. And we know we know how punishments work, so practices that cause harm. Absolutely. And if we expand harm the way I've proposed earlier, what does that open it up to? Is it ever necessary to give 2 cognitive assessments at that point? Probably not. And the fourth category is practices that are no longer needed. Well, this is a fun one. And I'm not going to lie to you. I spent way more time than I'm proud of trying to come up with good examples of this one. I really did. So a lot of this comes from or is adapted from the medical literature. A lot of this nomenclature and thought process. And their go-to example were the rollout of Ebola containment in Africa a few years back in like 2015. 14, 15, when we had the outbreaks. And then how once that outbreak was contained, they needed to roll back because those interventions were no longer needed. And I'm like, okay, that's useful to think about, but that's not a good one for an education group, right? What is something that is no longer necessary for us? It's harder. It's harder. This one could become relevant as standards change and what we expect of students change. So if we're no longer expecting students to do, and this is just an example, cursive, then interventions for cursive are no longer relevant. There's no way of commentary on whether that's an appropriate thing. Just an example. The one I like is differentiating social maladjustment from emotional behavior disorder. You know why that's unnecessary? Because they're not two separate things. We're very arbitrarily, I would even say subjectively, trying to decide which kids are worthy of treatment and which ones are not. It comes very much down to this sort of value-based, preferential approach to treatment. Oh, these are the good kids. They just have some issues. We can help them with that. Those are the bad kids. Screw them. Right? And that's largely where that process came from, if we're really honest. And if we track it back to Congress, it came from a desire to save money. But we won't go into that today. Oh, I'm sorry, that's hard to read. So deimplementation. Right, so we have our low-value practices. We have our criteria for how to define that bottom tier of interventions that we should not use under any circumstances, or we should only use with extreme prejudice or high levels of skepticism. So what if those are already in place? Things like patterns of strengths and weaknesses. What are things like balanced literacy, whole language learning? Fontes and Pinnell books, right? It's popular right now. And of course, I'm going to lean into that a little bit. So deimplementation is the process of eliminating or reducing the use of low-value practices, often within a specific context. So this goes beyond me sitting in my office writing a paper about how whatever is bad. That's not deimplementation. This is more active processes at the context level, the local context level, to actively get rid of things. First of all, before I move on, when I talk about a low-value practice, do any of you have a particular practice in your mind right now that you'd like to have gotten rid of? It can be clip charts. That's perfectly fine. It's a bit hard to do, but I think this next conversation is a little easier if you're thinking about a concrete application or practice. So the deimplementation process begins with identifying low-value practices and targeting them for removal. This is our problem identification phase. This is going to begin to look similar. And then you have contextual assessment. This is where you identify the barriers and facilitators to the implementation. So these come in a variety of different categories, and we'll talk about those a bit here. And those are things like social, political, economic, historical, and even pedagogical forces that maintain the presence of practice in the environment. One of the reasons it's so darn hard to get rid of things like patterns of strengths and weaknesses and cross-boundary assessment is because they fund NASP to do their conference. And so NASP can come out tomorrow and say, yeah, these things don't work, but we're still going to take their money and they're still going to present next week. And they're going to tell you exactly how to do the thing that doesn't work. And the thing about training people to do a thing is they then go and do the thing. At least some of them will. Not all of them. Some of them will. Social. When all of your peers believe a thing, you're likely to believe that thing, or at least pretend that you believe that thing right along with them. And when we're talking about a field like school psychology, which is surprisingly small and national at the same time, when we see so much endorsement of things in our field that frankly don't need to be endorsed, it's hard not to buy into that. And I'm going to say, even though I never put it on a slide for good reason, in this social category is the idea of gurus. We have gurus in education, counseling, and school psychology, even applied behavior analysis, that I love to spout off that X, Y, and Z is the next thing. I'm not going to name names here today. That is the next thing. It's the big thing. It's the best thing. And they get large followings. It's impressive the followings these folks can get. Their entire conference is built around them. And so that's certainly a part of this as well. When I wrote a paper on this, one of the reviewers came back and said, could you give some examples of gurus? And I said, absolutely not. Nope. That's not a cease and desist letter I want to get. Political. Right? A lot of times the things that we're doing that don't work are part of our regulations and laws. Right? They're in the SPED handbook. They're passed down from on high. Right? Like I can stand up here and tell you right now that bright line or rigid cutoffs for disabilities is bad. That's directly in confrontation to what we understand about how measurement works. And yet, that's often how our laws are written across the country. Like, oh, they have to have a 70 or below. If they're a 71, they are not ID, they're happily functioning. Right, and that's not always true. It's not always the case in every district, in every state, but certainly it is in many. So there are tons of these. And then historical is a fun one. Do you know, this is my favorite historical example, on the front page of the WISC, there is this lovely area where you can graph out the peaks and valleys of subtests and indices. Do you know what year that was invented? 40s? 1935 is when the book was published. But it was a book basically on how can we interpret the Binet scales so as to get away from this averaged cognitive thing. At the time, I don't even know if we were consistently calling it general intelligence or anything like that. They just didn't like it, and they wanted to get to sort of a ups and downs profile approach. So they wrote this book. There's not a lick of evidence in this book. It was just, here's a proposed strategy, and here's how it might play out. Of course, it's been refuted over and over again throughout the years. Kaufman stood against it in the 70s and 80s. McDermott and his group, and then Watkins and Canavez and McGill in the 90s and 2000s. McGill's still largely there fighting this fight. Kranzler and others have all been saying this doesn't work for almost 80 years. Historical. These things have been in place for so long and are so ingrained in our profession. We are the IQ testers. So to say something bad about IQ testing is to say something bad about us. Now, as a school psychologist, I'm offended by that statement. But I think for a lot of folks that is true. And think about it. You know, I mentioned a number of folks who've been researching and doing this work for years. There are only like 6 or 7 at a time who are doing that, and 40 plus school psych programs. So most programs do not have an expert in this area. They have a person, usually a first-year professor, because that's the burden they carry, who is forced to teach assessment. They've never taught it before. Maybe they're unfamiliar with the research. So they just do what their previous instructor told them to do, who likely did the exact same thing and did what their previous instructor told them to do, and so on and so on and so on. So we have these historical forces that maintain these practices in our fields. Third category, you have to put strategies in place to reduce or eliminate the LVP depending upon the LVP itself. And then we have to progress monitor usage rates. I don't think that's actually too surprising for any of us, right? That's what we would do for most problem solving. And then we have to evaluate the outcomes. If we're testing out multiple LVP reduction strategies, then we need to choose one or choose a subset of them. I will also say, folks, this last piece here actually, this piece here is almost entirely going to fail if you don't begin with policy efforts. A lot of this stuff is so heavily embedded in bad policy that if you don't start there, you are going to have a false start. What does that say about the work that we're trying to do? It makes it harder because often the folks who have set those policies are not really familiar with the way we work or what we do. Sometimes you can get the ear of a receptive legislator, not always. All right, let's move forward. Running low on time here. Let's get past that. So again, here's just putting those ideas into sort of an ecological model, sort of borrowing some of that depiction, and how the teacher or school psychologist or clinician is impacted by all these different levels, and how we may have to intervene at different levels to make a difference in reduction of these LVPs. So how do we do that? We train and educate stakeholders. First step, almost always. Materials, meetings, PDs, shadowing, consulting. Then we move to evaluative and iterative strategies. So we're assessing for readiness to de-implement. Do we have alternatives in place, et cetera? One of the things I think is hysterical is school psychologists are a lot like vacuums. I'm sorry, that was a terrible, terrible mistake. School psychologists are a lot like school psychologists that pour a vacuum is the joke I'm trying to get to and failing. School psychologists that pour a vacuum, when we see that there's a gap in what we should do and we don't know what to do there, we're going to fill it with something. And I don't mean you or you. I mean as a field, we fill it with something. We got PSW entirely because they said discrepancy was bad. Right? That's where PSW came from. Yeah. We have to support teachers and clinicians. We have to facilitate the new data collection. We have to facilitate and make simple the new processes. We have to develop interrelationships, identify champions, recruit and train leadership, build coalitions. We have to change infrastructure. Policy change comes back to haunt us once again. Can't mandate change without actually allowing for the change to happen. We need to change that record system, right? If our checklist for having completed an evaluation still includes that old practice, we still have to do that old practice or someone's going to send it back to us, right? We have to change the physical structure and the equipment. We have to make new strategies easier, simpler, reduce the response effort. We have to use financial strategies, funding innovations, altering incentive structures. One of my favorite things that I've seen over the last year is that some school districts are doing a buyback on Fontes and Pinnell materials. And so they're literally going to teachers and saying, hey, you bring us your F&P books, we'll give you money for it to get those things out of the classroom. It's beautiful. We have to adapt to the context we're in. We have to provide assistance, consultation, feedback. We have to engage with the people who are actually going to be implementing this. We can't just offer a commandment from on high. We have to assess and redesign that workflow. Because part of the problem with RTI, right, is we said, RTI is the way to go, we're going to do it. And then we didn't actually redesign the workflow. And so we ended up with a special education system that was still dependent upon psychoeducational evaluations. And now the question became, well, how do you fit those two things together? Well, first you get a hammer and a chisel, and you hope and pray that you don't break either one in the process. Of course we did, right? We absolutely have broken both in the process. We've ended up with more complex cognitive assessment. We've ended up with RTI that's ineffective. RTI that, as a result of poor implementation over the last 20 to 30 years, I would call a low-value practice. Why? Because the evidence that it works is insufficient. The evidence that it causes harm is present in some cases. Right? We've seen that due to implementation choices, some states are intentionally delaying intervention or intentionally delaying placement. Now, should we evaluate RTI by its worst implementation? No, we shouldn't do that. But we need to be honest with ourselves. We can't keep saying that, oh, this is absolutely the best way to go, thumbs up, move forward, if it's not working. So we need to ask hard questions, and I think thinking of it in terms of low-value practices helps us to ask some of those hard questions. I'm probably not at the right conference for this conversation, but I'm going to say it anyway. RTI is a low-value practice as it currently stands in implementation.
But when forced to choose between IQ achievement discrepancy, or pattern of strengths and weaknesses, or RTI, I would submit that RTI is the best of the three not-so-great options.
I would agree.
That's stolen from Matt Burns.
Depending on which
He
you're
says that all the time.
And Matt and I have had this very conversation. So the catch here is, what's the function of what you're doing? What's the function of what you're doing? If your function is to deal with that workflow that they failed to redesign along the way, then RTI is terrible. If your function is to get interventions to students who need them, RTI is the best option we've got. And so I do need to be careful in the way I frame that, and thank you for pointing that out. Absolutely, you're right. The trick here is, what's the function of the system we're working in? And unfortunately, because they failed to ever redesign that workflow in the purpose of this system, it is placement and not intervention. Yeah.
So then, if I may operationalize this perhaps and just to check my understanding of the others as well, I think maybe an operation. Oh, sorry.
Thank you.
I'm sorry. I know you can
Sorry,
speak
I'm
loud.
really loud. I know. So would, for example, your description of the workflow hasn't been redesigned, would
Right.
that be operationalized in perhaps maybe this manner? A system that is trying to design RTI, well, MTSS systems, and using RTI for eligibility decision-making,
Right.
but you have a group of psychologists who are still using either achievement ability discrepancy and or pattern of strengths and weaknesses. In other words, you've got a system that is service delivery oriented that could be useful for eligibility decisions, but your decision-making model has no connection to the MTSS system and logic.
Right.
Is that one, perhaps maybe one illustration
that is
of
one component of
Okay.
this workflow issue.
Gotcha. Okay, thank you.
Absolutely. And I'll add to that briefly and say the other side of this is, if you present folks with, we have two potential systems in place, one requires you to do more work and the other one requires me to do more work, which one are you going to choose? And then you have folks who are potentially doing those two things in parallel. The matching law tells us they're going to choose the one that's the lowest response effort. And as a result, we end up with poorly implemented RTI, poorly implemented interventions at the general instructional level. Tier 1, Tier 2. And because we have that, we have to keep the assessments in place. And so we are in a catch-22. So concluding thoughts is, I don't have a good answer. I don't have all the solutions for you up here. And I didn't mean for this to become a conversation about RTI and PSW and all that. Certainly, I'm happy to have that conversation. But the point about all of this is, we need to think, how can we maximize the good we do for students? How can we minimize the harm that we cause for students? And how can we take the context in which we work into consideration to make those decisions? Some additional materials. Oh, sorry. Solving big problems. We came back to this. We started with this. We're going to come back to it. It requires that we let go of discredited or unhelpful practices and workflows. And they're easier to identify. Discredited practices are easier to identify than unhelpful practices, right? And this kind of comes to that RTI versus PSW thing. PSW is discredited outright. I know there are lots of folks who will tell you otherwise. It is discredited outright. Shoot me an email with your concerns about that question, and I will send you the research, happily. I will break that paywall for you. I have them all on a USB. RTI, I think, is in many cases, not all, an unhelpful practice because of this workflow issue. And so that distinction is still messy, and I'm not going to pretend that it's clear to me always when it's a low-value practice and when it's not. So we need to be able to let go. Letting go is hard. Letting go of beliefs that we've held, often since graduate school, is hard. It's hard to think that the second, third, and fourth page of that WISC protocol are simply useless. You don't need to calculate anything beyond the initial indices. Different score calculations, hysterically, don't even have reliability estimates in the manual. If you believe that you want to be practicing with consistency, check the manual and see if they even support you in doing so. This is also true of the WJ, the KABC, the RIAS, etc. They don't provide those because they're terrible. It would make them look bad. We have to be careful about the theoretical orientation that we bring to the game. We need to be careful not to reject things out of pocket just because we don't initially agree with them. I didn't initially agree with what I'm saying up here today. About 2 years ago, I would have come up here and preached to the high heavens that RTI was the way to go for everybody involved. It's hard to do that when you look at the way it's actually implemented. I'm not saying it's not the best option. You know, democracy is the worst form of government until you consider all the others, right? Same boat with RTI here. RTI is the worst form of LD assessment until you consider all the others. We need to be humble about our beliefs. We need to have epistemic humility. We need to be willing to say, I believe this, but if I see enough evidence that contradicts my belief, I'm willing to let that belief go. And that's difficult, to say the least. If you have more questions, you can reach out to me. Here's my information. A version of this PowerPoint is up here along with some other articles, and I will be putting some more up as well, and I will make sure that Erica has this link. Yes, ma'am?
I just have a question. So what do you suggest we do? What do we suggest we do?
Yeah, what do we do?
With regard to what?
With regards to the assessments and identifying LD, I mean, right now I think what I'm getting is like there are flaws with every
There are flaws in every system. 100% agree with that statement. So what do we do? If all statements need to be conditional in this situation, unfortunately, if we have a good RTI process at our school and district, that's your best bet. Because you're going to get, in theory, empirically supported instruction to the students who need it faster. And really, at the end of the day, I don't care if you diagnose or classify someone as having LD. What I care about is if you address the deficits they're experiencing. The label is a means to an end. It's a key to a locked door, nothing more. The label doesn't matter. Ohio has it right. Ohio? Iowa. Sorry, Iowa has it right. I was just in Ohio and at 100%. Yeah, I knew I was going to do that. I did it. Iowa has it right. What matters is that you intervene on the deficits and you improve that set of skills. And so if your RTI permits that, move forward. If it does not, for whatever reason, I am actually a huge fan of achievement-based placement. I do a comprehensive achievement battery. I look for deficits in reading accuracy, reading fluency, reading comprehension, math accuracy, fluency, comprehension at various levels. And if they are below deficit, then I'm going to say they have an LD so that I can help them to get access to interventions. Now, academic PSW is what this has been flippantly called. Hear me out. Hear me out. Academic PSW. Effectively, what you're saying is, this area is really in deficit compared to where we expect them to be. And then you intervene on that. And what's funny is if you call it academic PSW, the funny thing about PSW law as it's actually written in IDEA is they don't actually specify cognitive assessment. They refer to cognitive processes. Academic skills are part of cognitive processes. And I would argue at least, that that is a more meaningful set of assessments you could do to identify at least areas of need, if not the specific intervention that you need. It at least gets you closer to home than a cognitive assessment would. So that's the best answer I can give you to that question. That's how I train my clinical students and my schools-like students to do it.
And there's 20, 30 years of evidence to support that position.
Yep.
Just looking at performance level.
Absolutely.
I mean, you can remember who it is, but there's no way to really discriminate between a kid who this is going back to IQ, a kid with a low IQ who has a 79 on a Wyatt versus
Yep.
a kid who has a high IQ and also has a 79 on a Wyatt. They both are terrible readers,
Mm-hmm.
right?
And
So-
the same intervention's likely to work if they have the exact same skill
Exactly.
deficits.
And then even more concurrently, some research, Drew and others, have demonstrated that really in the decision-making process, rate of improvement as we understand
Yes.
it right now
Mhm.
is a very poor predictor of eligibility. It
Yes.
really comes down to performance level.
It does.
And so tying back to what you were saying earlier about fidelity of implementation, I mean, I think you said numerous times that RTI, and I would agree, is not implemented terribly well in a lot of places.
Right.
But when implemented well, it can be very, very helpful.
Absolutely.
Flip that with cognitive pattern and strengths and weaknesses. We can implement that really, really well, and it still sucks. So
Okay.
we shouldn't be doing it.
Let me ask.
Sorry.
No, I'm gonna extend that, folks. If you had to guess the accuracy of perfectly implemented PSW, cross battery assessment, what would the accuracy be?
It's bad, but even if you could do it really well, consistently.
Yeah. Well, what's a guess? Anyone in the room have a guess? It is a coin toss. It's
Yeah.
literally 50%. Actually, 49%. It's worse than a coin toss. So save yourself the money on the protocols. Get a quarter, flip it.
I just add my 2 cents, I just think that we as a field need to uncouple ourselves from IDEA and special education law. Hear me out, I know that sounds crazy. But our focus should be on doing empirically based practices, and if that's not good enough for a hearing officer, that's just kind of how I feel about it. And if you can, and having been in due process, if you can sit there and explain why you did what you did, they don't know what they're talking about. So if this is what I did, this is my rationale, here's the research for it,
Right.
this is what I felt was best for the child, you've done your job,
So.
and that's that.
To sort of couple to that, Ryan McGill used to do exactly that when he practiced in California. He would do all their fancy PSW stuff that they required because it was required, and then he would interpret it academic PSW style.
So we can use that verbiage, academic, patterns and strengths and weaknesses in our PA reports.
So Pennsylvania regulation, and Dr. Farmer, I don't believe is aware of this, but in Pennsylvania, legally speaking, the regulations say there are 2 approaches to SLB determination, IQ achievement discrepancy or RTI. There is no provision in the Pennsylvania regulations to use pattern of strengths and weaknesses. Now, before you all freak out, many people are doing it, but I think you're putting the district at grave risk if there was a mediation, due process, or a court case, God forbid, and you or your colleagues use the term pattern of strengths and weaknesses. It is not permissible in Pennsylvania regulations.
What I would say is, I think you could use the approach that I described of using academic assessment to guide your intervention and do what your state and district requires so that you keep your job while helping kids.
And I should clarify, when I was referring to pattern of strengths and weaknesses, I meant cognitive profile.
Yeah.
To be crystal clear.
That's fair. So I said not nice things about things today. That's literally my job these days. I did this at an ABA conference recently, and it didn't go well. I was not talking about this stuff. I was talking about some of their preferred practices. Like, well, that doesn't work. There's no evidence for it. Let's talk about why. That's all I want us to do here. Let's talk about what works, what doesn't work, and let's talk about why and what we can do about it. And I will end on that note. If there are other questions, I'm happy to hear them. Thank you all for joining me today.
All right, let's give a huge round of applause to Dr. Farmer, who came to us all the way from Tennessee. He is an emerging researcher. We like to highlight some early career folks. Fantastic work there, and it really ties in. I know you weren't here for day one because it was after Trick or Treat, but our keynote address was all about our responsibilities as educators to follow the science and not the pseudoscience. Sarah McDaniel did a wonderful session, and that kind of is a theme, and sometimes revisiting our practices. Things like when you get a syllabus that has projectives in it and you change it, right? So anyway, so thank you again.